Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
The use of left-sided Impella microaxial flow pumps as a mechanical circulatory support modality is rapidly expanding in intensive care unit. However, standard life support and resuscitation algorithms are not directly applicable to patients receiving this therapy due to fundamental alterations in circulatory physiology. In today's episode, we will discuss emergency management and resuscitation of patients with left-sided Impella support. We will base our discussion on a recently published UK multisociety consensus statement. Our guests for this episode are two of the authors of this consensus statement. Dr. Waqas Akhtar is a consultant at Guy's and St. Thomas NHS Foundation Trust in the United Kingdom. Dr. Akhtar completed full postgraduate certification in cardiology, intensive care, and general internal medicine, with a particular interest in cardiogenic shock, heart transplantation, and mechanical circulatory support. He has received multiple recognitions from the NHS for program development and training in critical care medicine. Dr. Akhtar is the lead author of the recently published UK Multisociety Consensus Statement on the Emergency Management and Resuscitation of Patients with Left-Sided Impella Support. He was a recent guest on Critical Matters, where we discussed ECMO emergencies. Today, we're also joined by Dr. Vasileios Panoulas, a consultant cardiologist at Royal Brompton and Harefield NHS Trust, and honorary senior clinical lecturer at Imperial College London. He has clinical expertise that encompasses both general and interventional cardiology. Dr. Panoulas has a special interest in complex coronary angioplasty, transcatheter aortic valve implantation, and percutaneous mechanical assist devices for the treatment of acute cardiogenic shock. He is the senior author of the consensus statements we will discuss today. Vas, welcome to Critical Matters, and Waqas, welcome back to the podcast.
Thank you for having us back.
Thanks for having us.
So we'll start, Waqas, with your perspective, and you navigate both worlds of cardiology and critical care. Why should intensivists care about this topic?
Yeah, certainly. I suppose cardiogenic shock forms a smaller proportion of the shock that presents to ICU, normally about 10 to 15% in many ICUs in the UK. However, it carries quite a huge mortality, and that's not really improved over the last couple of decades. There's actually only two trials that have ever shown positive effect for mortality in cardiogenic shock, which was primary PCI and Impella, which Vas here was an author on. And I think it's really key that if we only have these interventions that can provide benefit to these patients, we really need to know how to manage these devices, because it's not just the insertion, it's the day-to-day care afterwards that's important to get the best patient outcomes.
Perfect. We would like to talk a little bit about the modality or the methods, actually the methodology that you used in the UK Multisociety Consensus Statement. Waqas, could you provide us a general overview of this consensus?
Yeah, so there's not really much out there in terms of structured algorithms or resuscitation practices to follow in patients who have Impella for cardiogenic shock. So what we did was we reached out to the highest volume centres in the UK, 11 of them, and we also collaborated with 8 national societies representing cardiology, intensive care, and multi-professional groups. And we tried to come together and provide an overview for those first couple of minutes when a patient deteriorates, and particularly within cardiac arrest, who's receiving Impella therapy support. And we tried to go through the data that is present, which was very limited, but was mainly based on iterative simulation to trial the algorithms, as well as clinical incidents that had been reported.
Could you tell us about the recommendation class and levels of evidence you use for this document?
Yeah, absolutely. So, as I mentioned, there's very limited data out. There's many case reports around issues when people have deteriorated with Impella therapy. There's some aspects about its routine management. For example, physiology can be very different. You can have a complete lack of pulsatility with an Impella, and many people who might see a patient who's got a ventricular arrhythmia and no pulsatility may assume that patient's gone into cardiac arrest, but that certainly doesn't always represent the case, and that's why a lot of this had to be synthesized from clinical knowledge, from iterative simulation, and incidents and reported cases. And so therefore the level of evidence is quite low. But there are some things that are well established about the routine management of Impella patients, which is why the recommendation is higher in some classes.
And you mentioned already that there was not a lot out there in terms of how to manage these emergencies in Impella patients. What else does this guideline add to the literature? What's unique about this guideline?
Yeah, so there is manufacturer guidance, of course, about troubleshooting Impella with the various alarms that can occur. However, this algorithm is unique in that it brings together troubleshooting for Impella device alarms and motor issues with a patient approach, which is well established in many other advanced life support situations. And so it brings together both the clinical aspect of managing the patient as well as trying to manage and troubleshoot the device, and tries to provide some prioritization to make sure that both things are addressed in parallel to provide the best chance of saving the patient's life.
Before we dive into the actual Impella emergency algorithm and the recommendations of the guideline, Vas, I would like to go over major concepts related to Impella, and would like to maybe start with a general explanation of what is the Impella device, what are its parts, what are the different types of Impella, a little about the physiology, and what's the ideal position from your perspective as an interventional cardiology who's placing a lot of these.
Yeah, in essence, Impella is a microaxial pump that you put percutaneously, or also you can put it via surgical cut down. There's two Impellas that are supporting the left side of the heart, the left ventricle as we call it, and these are the Impella CP that can pump normally up to 3.5 to 4 liters. And then you have also the Impella 5.5 that is a surgical device, and that can produce even more. Normally people use it up to 4.5 liters and 5. And this is normally put with surgical cut down via conduits that you normally sew either in the axillary artery or could be also direct aortic. There's also Impella RIJ that is used for the right ventricle, which is a bit more uncommon in clinical practice, but it's another device that you can use to support the right ventricle. In essence, they have a propeller that spins at thousands of RPMs per minute. And in essence, you continuously suck blood from the left ventricle through the inlet of the device, and you pump it out into the ascending aorta. So it's like a continuous flow pump. It doesn't really care about systole diastole, even though as a flow pump, it really relies on the pressure difference between the inlet and the outlet. And it's more efficient when there's less of a gradient between the left ventricular pressure and the aortic pressure. So we normally, and as a pump, it's been there for now decades. So I think across the world, there's been several hundred thousands of Impellas that have been implanted for several indications. But the concept of the device is quite simple. If you see a speedboat and you can see the propeller of the speedboat, that little type of propeller is inserted into one of those devices, connected to a motor. And then in essence, that motor spins that propeller, and the propeller creates this principle of Archimedes screw where it basically sucks the blood. And that's in essence how the device works.
Excellent. In terms of clinical trials, Waqas did mention the two therapeutic modalities that have shown differences in outcomes in patients with cardiogenic shock, and one of them was the Impella. Could you talk about the DanGer shock trial? What was the aim, what was found, and what are the implications for clinical practice?
Yeah, so the DanGer shock was published in April 24 in New England, and it was a result of many years of recruitment efforts done initially by the Danish team led by Jacob Moller. Then Germany joined the effort, and finally also our center from the UK. Unfortunately, we couldn't change the name from DanGer to DanGer UK, but we're still debating that. But in essence, it's a big randomized trial of 360 patients half of them were allocated to having the microaxial flow pump, the Impella, and half of them standard of care. It was done only for patients with ST elevation MI that came with cardiogenic shock. And the definition of cardiogenic shock would include echocardiography. So you needed to have a left ventricular ejection fraction under 45%. And also you need to have biochemistry with lactate of over 2.5 or SVO2 is under 55%. And systolic blood pressure under 100 millimeters of mercury. So this was the definition of shock. And what is very different between this study and the ones that have been carried up to that moment was the actual definition of shock. It's probably the first study that involves and includes in the definition echocardiography. And for me, that was an eye-opener, and one of the big reasons I wanted to participate and take us into that trial was the simplicity of the entry criteria. Because when the primaries come to your door, to your cath lab, the three weapons you have, I would say, is the clinical ability to see someone and examine them. Then you have, obviously, the observations, the systolic blood pressure, SATs. You can take a gas and you can do an echo. So, and this study basically encompassed all of those. And what was the hypothesis was to show whether routine use of the microaxial flow pump would lead into a benefit in terms of mortality at 6 months. That was the primary endpoint, mortality at 6 months. And what was excluded was people that had mechanical complications of MI, severe RV dysfunction, any contraindications for putting an Impella device such as LV thrombus, for example, or metallic aortic valve. It just showed at the end, the primary endpoint, it showed a big reduction, nearly 13% absolute reduction in the risk of mortality at 6 months, which in fact in the sub-analysis that there was an age-related sub-analysis showed that if you're under 77 years of age, you would get an even higher reduction in mortality that was reaching 20%. Which means you only needed to treat 5 patients to save a life. And that's why I think this study was a big headline in terms of net clinical benefit for the patients. Of course, since then, we have had several sub-analyses of the danger shock, trying to deep dive a little bit in the mechanistics of why does this effect happen. And also we had the other New England paper that showed the long-term effects of the use of a microaxial flow pump compared to standard of care. And it showed that benefit seems to continue over time for up to nearly 10 years. And we suspect that this probably is because of improved LV ejection fraction. So one of the most eye-opening sub-studies of the danger shock was the sub-study on hemodynamics, where it basically showed that there are big reductions of the mean pulmonary arterial pressure as a result of the Impella pump, and also a big reduction of the native cardiac output. What does that mean? That means that intensivists, in essence, were using less inotropes that had much lower vasoactive inotropic score, and that heart that just had a recent MI was resting appropriately and recovering appropriately. So, in essence, not only probably Impella facilitated a survival of people that otherwise wouldn't survive, but also the recovery, the better recovery of hearts, and probably more impressive gains and improvements in terms of ejection fraction by the end of the hospitalization. Even though we haven't actually shown that with actual figures, the fact that the long-term results suggests that the Kaplan-Meier curves keep diversifying from each other, and that is suggestive that probably the main reason was an improved pump function. And I will stop there so I don't prolong this answer.
No, perfect. And these are all very important observations and a landmark study, obviously, because we tend to jump into new technology very quickly. People are enthusiastic about it, but it's always from previous lessons in other areas good to have the data. And on one hand, I do believe that this is a very specific patient population, right? And we're using Impellas in a wider population at clinical practice, and I'm sure more studies will come. But the other aspect of the danger shock trial that I would want to hear a little bit from your perspective is that these devices are not without complications, right? So managing them appropriately and being very judicious in terms of selecting patients is also important. Any comments on that, Vas?
Yeah, no, absolutely. That's a very fair point. And before I forget, because I think I didn't mention it, it's important to also note that danger excluded comatose cardiac arrest patients. So people that had prolonged downtimes and we didn't know their neurological status were not included in the study, because as you mentioned, previous studies had included them, and then neurological injury kind of tends to mix up the results. So arrested patients were included, but as long as we had evidence that they were not comatose. So in terms of complications, you're absolutely right. Every device comes with its complications, and generally MCS devices, mechanical support devices, are notorious for excessive bleeding. And for example, something we noticed in danger was that bleeding complications didn't always come from the access site, which is kind of the common belief. Something less than a quarter came from the access site, but also we noted that more than 50%, 50.3 if I'm correct, percent of the bleeding happened after the removal of the device, which means that MCS, and particularly in the setting of an acute MI where people get antiplatelets, has big rheological implications on anticoagulation. So as such, you could see bleeding events even after you remove the Impella pump, and that's what we also noticed in danger. So, and what are the other complications that you get? So bleeding was around 23%. Then you get renal filtration that was quite high, something around 44%. And that's a combination of selection bias, where basically, people that shouldn't have survived and had multi-organ failure, etc. And as a result, they needed filtration. But then there were also some device-specific parameters that potentially led to more hemolysis, and these were suction events. And in my books, that normally means that the Impella device was either positioned in an inappropriate place, so under the mitral papillary muscle, that can happen quite easily. And number two, it could be because you had a big blood loss or volume loss, and as a result, you're suctioning on the ventricle. Or number three, because you had an RV that was also not coping in the end, and you didn't manage that appropriately. And suction events seem to create more hemolysis. And we know that hemolysis can be very traumatic for the kidneys because of the plasma-free hemoglobin that tends to create AKI very easily. So, and the other Impella-related factor for AKI and renal filtration was the higher speeds. So if you use a device, and we were advised to use a device at higher speeds, but sometimes we would go down to P6. P6 is like the power level, and you can go from P1 to P9. So if you use it at P8, P9, you're more likely to cause more hemolysis because purely of the speed of the motor and the propeller. So these kind of AKI infiltration was one of the highest numbers of complications. And then you'd have a small percentage, around 5-6% of limb ischemia, and some sepsis that was also associated, because obviously you have a device, people can get infections of any sort, and obviously whatever you have in the body can precipitate the infection. So the infection sites were also slightly higher than the control arm. But I think the most prominent strokes were, again, very little. I think the most prominent two that seem to have been highlighted is the bleeding and the filtration. And I think a lot of it we can improve both as interventional cardiologists, but also from an ITU perspective on how to manage those devices, because there are tips and tricks and best practices that we can promote to reduce the number of complications that we get on the device. But obviously you need constant education, and you need simulation training. And there's several courses that people can go on and educate themselves. But I think it's also good through this podcast to be able to advertise them, because in each country there's always courses related to the management of Impella and its complications. And I think people have to go there as a team. It shouldn't be just the interventional cardiologist. It should be the whole team that manages those patients from the beginning to the end of their journey. And I think that's the only way to tackle the complications.
Absolutely. You mentioned the position, and when we talk about the emergency response, we'll talk about malposition alarms. What's the ideal position of an Impella catheter device?
So in essence, for the CP, that's like the most commonly used and is transcatheter, you want to make sure that the pigtail of the device is pointed towards the apex and that you're not trapped under any mitral papillary muscle. Normally, they say that the distance between the aortic valve and the inlet should be around 3.5 centimeters, but obviously that can vary a little bit. I would say at least a centimeter up or down, depending also on the LV size, because obviously you can put an Impella in someone with dilated cardiomyopathy and a ventricle of 8 centimeters. The Impella will be sitting a bit more deep to make sure that it's stable. But what I normally advise people is to, when they cross the aortic valve, because that's the kind of critical step to put the Impella in exchange for the wire, you go to an ario position in the cath lab or ario-caudal position in cath lab, and that's basically like your three-chamber view on TOE or transthoracic echo is a long axis view. And then you can actually see whether your wire or your pigtail is free before you position your Impella. And then do your Impella implantation, but then obviously at the end, before you leave the cath lab, and because obviously there is a step that you have to exchange the pilloway sheath for a blue repositioning sheath, you want to make sure that Impella does not move. And before you leave the cath lab, you do a final check, both fluoroscopically, but also with use of echocardiography. Because if you send someone to intensive care with an Impella strap under the papillary muscle, what's going to happen? You're going to get more suction. People will come and play with the device. Inevitably, someone might also remove it altogether from the LV, or someone might push it too hard and create a perforation or a problem with the mitral papillary muscle. So you basically open yourself to several complications that can happen down the line. So a very simple and easy step is, once you're done with this procedure and you have ensured that you put it in the right place, facing towards the apex, 3.5 centimeters, as we said, free from the papillary muscle on the area of use, do a final check with echocardiography, make sure everyone's happy. Note down the number on the Impella shaft that's coming out of the leg and make sure that that number is documented. It's like simple steps. Make sure you secure the device with a TUI boss so that it cannot be moved during the transfer of the patients, because all of that adds up. So these little best practices, and I think also the company has created a list of those, but these are really important steps to make sure that you get it placed in the right position, but also you maintain that placement. So no one down the line from the cath lab to the intensive care, wherever that patient goes, moves the device, and then you end up inadvertently having complications that you don't really want.
Perfect. We talked about ST elevation with cardiogenic shock as an indication in a danger shock trial. What are other common applications or clinical uses for Impella today that you want to mention?
Yeah, so in hospitals that face patients with cardiogenic shock like ours, we're like a quaternary center and transplant center, we get a lot of referrals for cardiogenic shock from various etiologies. And the reality is that AMI is only accounting for about 44% of patients in cardiogenic shock. So you see a lot of patients with, for example, myocarditis, and that's an excellent example where Impella can be used to rest that ventricle and allow for recovery. Often these patients sometimes can be rescued on ECMO, and then you end up with ventricles that are totally overloaded, aortic valves that don't open, and the risk of thrombogenity and clot formation in the LV is very high, and there's like an emergency unloading that has to happen. And you can do that very nicely with an Impella device. Then there's this progressively deteriorating end-stage heart failure patients that, for example, DCMs or ischemic cardiomyopathies, that are sliding down and they're heading towards transplantation. And despite your little inotropes, Milrinone, or whatever you like giving, they keep that gradual deterioration. And then you put them in an Impella device and you bridge them very nicely to transplantation or advanced therapies, LVAD, etc. And of course, there will be also that cohort of patients with cardiomyopathies that come in as a first presentation crashing, and you can always offload them and put them a 5.5 device that supports fully their left circulation. And invariably, the right, even if it's moderately plus impaired, can cope. And then you can start loading these people sometimes often with good medical therapy and guideline-directed medical therapy. And we have seen a decent cohort of patients. I'm aware of a publication that also shows that you could recover some of these hearts just with guideline-directed medical therapy whilst they are on the device 5.5. And then, of course, there's a big use of Impella for what we call protected PCI, particularly when we want to do very difficult procedures that we have been doing traditionally, even without support. But it has been it's a scary process for the operators, and often is a quick job, as I call it. So you go in, you do the best thing you can with balloons and cutting balloons and stuff as quickly as you can, and get out as fast as you can. And sometimes you don't do quite a good revascularization job. So Impella tends to provide that support for these patients that gives the operators the confidence to do a better job and use their, rotablations, their lithotripsy balloons, their cutting balloons, and get as good a result as they can get for that patient. So these are kind of the main areas. I think if I was to sum them up, it would be the kind of high-risk protected PCI area. And it's exciting. We have 2 randomized trials coming up. Already we had the PROTECT 2, that's quite an old trial. But now we have the BASIS CHIP 3 that we'll announce in ACC, and we will have the PROTECT 4 next year. So we will get more information about potentially which are the patients and patient characteristics that could benefit, and how exactly what kind of maneuvers we should do as operators to give the patients the best benefit. So high-risk PCI is one arena, and then is the cardiogenic shock that not only involves ST elevation MI, but also involves all these end-stage cardiomyopathies that could be ischemic, or it could be DCMs, or it could be myocarditis that benefit from the device. Obviously, for this later group, there's no randomized evidence yet, but I think it's very difficult to have randomized evidence, for example, for a 35-year-old that dies in front of your eyes from pump failure and myocarditis. It will be very harsh to randomize that person to MCS versus no MCS. So I think we will never see randomized evidence for the later group, but I think it's nice to have, at least with danger, some randomized evidence on the AMI arena to show that in certain populations, there's danger-like patients, as we call it, there's a big benefit. And I'm hoping that, we will carry out more studies in the future, and that's a reality. On our world of evidence-based medicine, this is how we like to evolve. And I'm really hoping that we will be part in this journey in the future as well.
Within the indication of cardiogenic shock, and obviously you were talking about a wider group of patients here, just beyond ST elevation, acute MI. When is Impella useful on patients who are already on ECMO?
Yeah, that's a very good question. So in essence, when you have someone on ECMO, you use the Impella as what we call an unloading tool. Even though that term is quite a difficult term for people to understand, unloading means trying to take away some of the energy that the heart uses. And ECMO, in principle, can unload the heart because basically it reduces the preload. So it reduces dramatically the volume of blood that goes into the heart. The problem with ECMO is most of the times the afterload, which we can basically name it also the mean arterial pressure that we create once we put someone on ECMO, tends to go up. And if people are not very careful about managing the afterload, they can lead into an LV that is distending and a heart that its pumping ability goes down. So when is Impella useful in these patients? There is ongoing randomized evidence that will tell us exactly when, but until that happens, I think in our hospitals, We think that Impella is quite helpful when you see very low pulsatility, so the pulse pressure is very short. And I'm talking about, under 20 millimeters of mercury or less. When you have aortic valves that do not open, and then the patients are at risk of clot formation, both within the left ventricle, but also in the aortic root. When patients go into profound pulmonary edema, and if you have a catheter, you see, LVDPs that are more than 30 millimeters of mercury and wedge pressures that are sky high. These are the kind of cases where an unloading with a Impella device really solves the whole problem. Obviously, the next natural question is, why don't we do it on everyone? We don't do it on everyone because double the device, double the risk of complications. So, bleeding on the combination of the devices can reach up to 60%. So simple stuff like that. Same thing goes for hemolysis. So the clotting abnormalities you get on the combination is quite remarkable. So I think teams have to be very well geared up on managing these devices if they want to manage them together. But obviously, if done properly, you can get some phenomenal saves. And in our institutions, where me and Waqas work now, we're one big trust, Guy's and St Thomas, that has all three hospitals. We've seen several cases that have been managed with Impella and had a great outcome. But as I said, we need to be cautious and work in a multidisciplinary way to get the best outcomes for these patients, because they're never very easy. They're always very difficult to manage.
Excellent. Let's talk about Impella emergency algorithm and the actual recommendations from the consensus statement. Waqas, could you walk us through the core principles? And I do believe that there's something really important here to emphasize in terms of how we should approach these emergencies in terms of team allocation.
Yeah, of course. So the algorithm is very much designed for those first couple of minutes when a patient goes into cardiac arrest, but it can be applicable to many emergency scenarios, so you can translate some of the interventions to those situations. But importantly, it's not meant to be a standalone document. I think there's a couple of things. One is that you have to have regular clinical familiarity with Impella, and I don't think you can override the importance of that. And I think secondly is that it needs to be complementary and implemented through the provision of structured training. And it's really important, I think, to have simulation as part of that so that you get familiarity with the device itself. But yes, the structure of the algorithm focuses on, in parallel, working with a team that focuses on the Impella and a team that focuses on the patient, because they're slightly different skill sets. And it may not be teams necessarily who can do both of those functions, but it's both important that are present, and then ideally having a team leader who can oversee both sides of the interventions that are occurring, and that's pretty much how the algorithm structure follows, and is very similar to strategies that are employed in ECMO and other forms of mechanical support when patients deteriorate.
What's the initial, in terms of the initial response, what triggers an Impella emergency?
Yeah, so for this algorithm, we specifically looked at cardiac arrest. So the initial thing we specified was that the patient should be unresponsive and or not breathing normally, which is a normal entry point for most advanced life support algorithms. Importantly, most Impella patients, especially in our institution, are not intubated or kept asleep, so they're actually awake. And particularly with our 5.5, we expect them to be mobilizing in preparation for bridge to transplant. CPs are normally not mobilized unless it's put in a more secure manner. So the unresponsive or not breathing normally is an important entry point. And then there's a real lack of evidence about what you should be using as criteria for defining a lack of adequate circulation. So end-tidal CO2 has some evidence, and the American guidelines particularly have used it in some MCS troubleshooting algorithms to have a end-tidal CO2 of less than 2 kilopascals as a cutoff. But as I mentioned, not many patients with Impella on institution are intubated. So therefore, we use MAP really as our entry point. And again, that lacks any evidence. But through consensus, we agreed that mean arterial pressure that's been checked in terms of the transducers adequately functioning and leveled, less than 30 millimeters of mercury as a entry point into the algorithm.
So in terms of numbers, less than 30 millimeters of mercury for blood pressure, and you talked about end-tidal CO2, less than 2 kilopascals, which would be less than 15 millimeters of mercury for those who use that denomination, right?
Yeah, exactly. And I think it's important that there's no one tool you can use. So it's often the trend of the patient, how they're behaving, and particularly if they're intubated, it can be quite difficult. But I think that on balance is probably the most pragmatic way, at least until there is some evidence, because there's likely to be a deficit of trials in this area because it's not very clear what an adequate circulation is. And I think that's well defined within cardiac arrest, where you have some of these people who are immortal survivors, even through prolonged periods of resuscitation, and actually whether they have some ability to maintain sufficient flow to the brain, even at lower maps, to prevent poor outcomes.
Before we talk about the actual interventions, what's different about a cardiac arrest in somebody who has an Impella? Is there any particular difference that you want to make sure you emphasize?
Yeah, so I think the recognition is important. So I think that's one key thing that I've often picked up, even within our institution, because we have lots of rotational staff who come through, is the lack of pulsatility, which clearly is not something you want to have. You want to make sure the heart is ejecting well, but it very often does happen at the start of Impella therapy, especially as Vas mentioned, you want to have a reduction in your vasoactive use, so you want to maximize the amount of support you can get from the Impella. And often in those situations, people will have a lack of pulsatility on their arterial line. So I think it's important recognition that that is not inherently so a problem, especially if you've got adequate perfusion pressure with your mean arterial pressure. I think the other aspect is just the device itself. If you're going to be starting CPR, there obviously was some FDA notices previously about perforation of the LV with Impella mount placement. And I think it is an important consideration in CPR, although we've never seen it, is that CPR can obviously cause the heart to distend and the device to migrate. So it's an important consideration, and particularly with patients who might have particularly aneurysmal or thinned left ventricles. However, pragmatically, if you've ascertain that the patient doesn't have an adequate circulation, then you're not really going to have much option other than to be able to perform CPR while you try to remedy the situation.
Is there any intervention with the Impella when you start CPR?
Yes, so the company recommends a reduction in your P setting. They don't specify in their manual exactly how much, but in the algorithm we decided to recommend a reduction to P2 before starting CPR. And the reasoning behind that was you're going to get movement of the device during CPR because it's often not going to be completely fixed in place, and obviously your heart is going to be moving around the device as well during CPR. And what you don't want to end up doing is having the inflow, which if you actually look at the device, is almost quite a sharp cage near the end of the device. And if that was to be at a high P setting and cross into the aortic valve, there's a possibility that it could entrain the aortic valve leaflets and cause significant amount of damage. And then if you've got a patient who was already deteriorating and potentially had gone into cardiac arrest, and then you render them with torrential severe aortic regurgitation, that's not only going to hamper your ability to get them back, but actually if you're going to have to rescue them with additional mechanical support such as ECMO, that's going to provide even more difficulty because most mechanical support doesn't function well with severe and torrential aortic regurgitation. So that's why we recommended a reduction to P2 before starting CPR.
In terms of the recommendations, the priority, obviously, in these cases is to restore circulation by either resolving device dysfunction, which is what the Impella team is trying to figure out, or that caused by physiological problems, which is what I guess the patient team is trying to figure out. Can we talk about the Impella troubleshooting? And maybe, Vas, you can walk us through how we should think about the potential problems. Obviously, these devices have alarms that tell you this might be a potential problem. But what are the main categories, and what do you recommend our listeners to be thinking about?
Yeah, absolutely. I mean, there's obviously a million of alarms that you can get, but I think for the matter of time for this podcast, I think it'd be nice to highlight the most frequent problems that you can get with a device. And I think the number one that we experience is the suction alarm. And as I mentioned before, a suction alarm basically means that your inlet of your device, where that little cage is, as Waqas mentioned too before, is stuck to the LV wall. And why could that happen? I think can only happen in three big scenarios. And in fact, if you see it completely like theoretically happens because the LV has very little preload. And why would the LV have little preload? It could be because you have a lack of intravascular volume. So either you're bleeding from somewhere, it could be the Impella site of access, or it could be another big GI bleed that you're not aware of. So number one, volume loss generally in the circulation. Then number two is, as we mentioned before, bad positioning of the device. So if the device is put under the mitral papillary muscle, for example, it's much, much easier to create suction alarms. A lot of these devices can be headed towards the mitral on the posterior wall. And there's very nice papers out there that now comment about malpositioning and ways to identify that, both with echocardiography, but also in the cath lab. And if I just mention the two fluoroscopical approaches that all operators should be doing, one is the aerial caudal that, as I mentioned before, is like the long axis view of echo. And it opens up your LVOT, LV, and left atrium. And then there's the LAO cranial view that basically is the equivalent of the four-chamber view, and you can very clearly show whether that impella is heading towards the lateral wall under the mitral papillary muscle. So positioning, very important also for suction. And the third and often under-recognized situation that leads to suction alarms is RV failure. And a lot has been said about RV failure and how you diagnose it, but I think predominantly you need hemodynamics to be able to diagnose RV failure, and that includes your pulmonary artery pulsatility index. That means you need to have a PA catheter in, but also obviously more simple things like the CVP when that goes up, and yet you have an empty left ventricle. You have to figure out what's going on. But I think these three main factors are the one that lead to suction alarms. And then two other very common alarms that people should be aware of is when your motor current, and that's the little green line on your device, is flatlining. And that normally flatlines when the device is both inlet and outlet of the device is in a single chamber. So either the device has gone all the way into the left ventricle, or the device has come off in the aorta. And when that happens, you will get a respective alarm. But when the device is in the aorta, the arterial trace of the device will show an aortic trace, an arterial trace. And when the device is all in the left ventricle, you will see a left ventricular trace. Of course, there can be other problems related to the purge pressure, etc. But this can be a little bit more complex. And I think for our listeners today, for the purposes of this podcast, probably we should just focus on these main alarms, the suction alarm, and then the positioning alarms that are probably all of them relatively easy to solve in a quite rapid fashion. The other thing that we should note, if someone has, for example, tamponade, you might again get a suction alarm. That's quite rare, but can happen, particularly when you have coronary interventions preceding the admission to ITU. You also should be wary that if you have someone with tamponade, again, what happens is you reduce the preload to the left ventricle, and it's very easy to create a suction alarm. Similarly, if you have someone on ECMELA, so ECMO and Impella combination, if you really go very high up on the ECMO RPMs, what you're going to do is you're going to reduce massively the preload to the left ventricle. And if at the same time you're running your Impella at a very high power, you will end up diminishing, and sometimes you can totally make the left ventricular cavity disappear and have again a very nice suction alarm. So a few things to think about, but suction alarms are the most common headache for ITU teams for Impellas, and I hope this kind of brief talk makes it clear for people to look for reduction in the intravascular volume, positioning of the Impella. You can call it malrotation, you can call it malpositioning, whichever way you like, and problems with the RV failure. And of course, be careful when you have ECMO and Impella ECMELA configurations.
Excellent. And just in terms of summarizing, obviously for suction, consider improving preload by giving a bolus. I think the paper recommends starting maybe with 2.5 mLs per kg as a starting point. A very important aspect that I want to emphasize is the importance of exposing patients and really looking at all insertion sites, looking what's going on. Is there bleeding, right? Could be causing this, as you mentioned. And then for the Impella position unknown, it's either too far in or way out. Looking also at the arterial trace lines. If it's too far in, you will see the LV trace, and the action there is under echo to pull back the catheter to the optimal position. And if it's too far out, you'll see more of an aortic tracing. And again, echo guidance to reposition it and then come back to the previous P setting. Since we mentioned we would go to P2 when we have these problems. How do you evaluate adequacy of circulation after you do these interventions?
Just before I mentioned that, I think to highlight when the Impella is out in the aorta, it depends whether the pictal part of the Impella is still in the ventricle, in which case you could reposition with echo. But if the whole Impella, including its little pictal, is out in the aorta, I would probably advise strongly against doing it with echo guidance, because that might create a complication. So this probably has to be done under fluoroscopy in the cath lab. Now, going back to your previous question about adequacy of circulation, I think, again, in arrest situations, most people focus on some basic hemodynamics, and it depends what you have at the time of the arrest. Obviously, we all look at maps, and normally most teams like to have a map around 60, 65. Of course, there's also now the North trial running that might lower that threshold, but that's roughly the immediate response that we want to achieve. And start having good and tidal CO2s. Then if you start going and looking at an echo, you want to make sure that you have a LVOT-VTI that's slowly creeping up, and you don't have profound RV failure that you need more support. Of course, you can go to more advanced hemodynamics. You can check your cardiac output, cardiac power outputs, your PAPIs, and then last but not least, your biochemistry, because ultimately, if everything is going well, what you're going to see is your lactate will start to reduce. You will see good oxygenation, and you will also see that these people have good end organ perfusion. For example, they might start peeing again in the good amounts. So these are the common things that we look for. Some of them are more immediate than others, but I think it's always a holistic approach. And of course, the clinical bit is also very important. Simple things like capillary refill time and stuff like that, reduction of the mottling of the patient, reduction in the inotropes that you need to use. All of that is clinically very important. Waqas can also add, because he's the master of intensive care. So.
No. So I think that's exactly right. And the echo, the couple of things in the algorithm design. So one, echo we didn't include till a little bit later on during the assessment stage, because often it takes you at least a couple of minutes to even find an echo machine and turn it on so it's ready. Otherwise, it would have been implemented much sooner within the algorithm. As Sebastian said, it's extremely useful to really assess pathology such as tamponade or ventricular dysfunction. And with regards to the traces, we discussed the Smart Assist is a very useful tool for identifying a malposition in particular, but actually it's only present at P4 and above, and so therefore we didn't decide to include it in the immediate algorithm, because as Vas described, actually having the motor current is actually probably the best indicator if you've got a flat motor current that you have an issue that you may need to resolve. And so those are just 2 points in the practicalities why those were ordered in that way within the algorithm. And then obviously aligned with all the Impella troubleshooting is the patient aspect. And we were very specific that you should just follow normal advanced life support protocols for that. Obviously, it does add a bit of complexity around ventricular arrhythmias, because as we described previously, people can tolerate those with an Impella in situ. So that would be the equivalent, for example, of a pulse VT, and the patient is conscious or has got an adequate map. And in that case, within ALS, we didn't decide to deviate in terms of the use of adrenaline, for example. However, it's important consideration, as Vas said, that the afterload is a significant issue for mechanical support devices. And for example, within the ECMO algorithm, we thought it was of significant enough concern to limit its use. But in this case, we would recommend normal ALS protocol, but be considerate about whether the patient actually does have a perfused rhythm with the ventricular arrhythmias.
Waqas, any comments on holistic care aspects?
Yes, I think it's really important, because we do all these things to try and save the patient's life, and we can be very invasive. So, we were talking about PCI, interventions, Impella, and then we might also be talking about ECMO and Impella, and these are all incredibly invasive things. And we have to make sure that we're not making our patients suffer without having a significant likelihood of recovery, and also really considering what it is that the patient actually wanted. And very early on, we'll make sure we involve our palliative care team, who are excellent, as well as family liaison teams, in terms of interacting to understand what the patient's values, preferences, and the lived experience, to allow us to align our treatment strategies with that individual's goals and priorities. So I think that's really important in the overall care of the patient, but also within the active resuscitation phase, which in the UK we've been a very big proponent of, is to make sure that we give the opportunities to families to be part of the resuscitation effort, to come and watch if that's something that they want to do. Of course, many may not want to do that, but I think it's important that consideration is made.
As we close and summarize, any pearls and pitfalls that you want to share?
Yes, I think Vas highlighted a couple of them, which I think are really key, that I think are quite common errors in management of Impella. So one is positioning. I think it's really key to get your optimal positioning, particularly in the cath lab, before they come down to the intensive care units. And I think it's often the case that people, may not have initially suction, and you're overall happy with the device. But actually, if it's not optimally positioned, for example, if it's intermittently abutting the septum or the mitral valve apparatus, you will end up getting some hemolysis, and that is likely what may be triggering a significant proportion of renal injury to these patients. And therefore, we monitor in our units plasma hemoglobin every day on these patients. And I think it's really important to get that optimal. And similarly, in terms of positioning, I think groin position of the device can often be an issue. So there is a little bit of an issue with the fact that the sheath that's left in at the end is smaller than the hole that you've made. And actually, the angle that the Impella goes in is really key, and we emphasize keeping it at 45 degrees and making sure the insertion sheath is fully placed. And actually, if you are having bleeding issues, Vas and our cardiologist place ProGlides in, and those can be cinched around the device to reduce bleeding, rather than the traditional pressing really hard and putting a compression device over, which I don't think is necessarily always the best option in these patients.
Excellent. As we close, we'd like to ask a couple of questions unrelated to the clinical topic. Waqas, Vas, are we okay with that?
Yeah, sure.
Absolutely.
Vas, you go first. What music album or playlist would you want with you in a prolonged isolation period? Example, you're in a deserted island or a new pandemic comes in.
Well, I have a few favorites these recent months. One is Teddy Swims on Learning. Then I really like Miles Smith. It's got some really uplifting songs. And Alex Warren, if I want to get a bit depressed at times. So I think these are the three tops at the moment in my playlist.
Excellent. What about Waqas? What would you want?
I suppose at the moment, I'm mainly listening to Bon Iver, his newish album now, Fable. It's got a really excellent range of songs. I could listen to that for a long time.
Perfect. Waqas, we'll continue with you. As we close, what would you want every listener to know? Could be a quote or it could be a final thought.
Yeah, funny enough, I was on TikTok and I thought this one really resonated with me. Is that we often worry in our lives a lot about decisions, research, career development, all those things. And we see a lot of death in intensive care. I think it's important in the context of our busy, stressful lives to remember to live our lives and enjoy them.
And Vas, we'll let you finish the podcast. What is the thought or quote that you want to share with our listeners?
For me, I think the most important, because a lot of people talk about work and life balance, but often work is also our life, and we love doing it. I think when you tackle complex patients like the ones with cardiogenic shock, just always remember to be a team. Stop the hostilities between one subspecialty and the other, and just join up together forces to beat this thing that's called cardiogenic shock. That is very complex to face. Someone's cannot do that on their own. So just be a team and love each other and work together.
I love it. And at the end, we don't own the disease. We just owe it to our patients to give them the best possibility to survive, and teamwork will definitely give them that. I want to thank both of you first for the wonderful consensus statement. It addresses a growing area, a very important aspect. I also want to thank you for giving us the time and your expertise today, and look forward to having you back to talk about cardiogenic shock. Thanks, Waqas. Thanks, Vas.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.